Good morning, namaste, and warm greetings to each and every one of you once again on behalf of Team DentistChannel.Online. We welcome you to a second session, to another Power Pack session, because, ladies and gentlemen, the next speaker is Dr. Vivek Gaur. Dr. Vivek Gaur, as you all know, is a name synonymous in the implant dentistry world. And that is not because of the number of cases that he's done. That is only because of the kind of mentorship, the kind of experiences, and the kind of challenges that he's been through. And that is the reason he is what he is. And that is the reason why I proudly tell you that Dr. Vivek Gaur is a name synonymous in the implant dental world. If it's immediate functional loading implantology in India, then ladies and gentlemen, the first person who comes to everyone's minds is none other than Dr. Vivek Gaur. So once again, Dr. Vivek Gaur, it's my privilege, pleasure, and an honor to welcome and invite you for the second session on the topic Simpladent, one-stop solution for immediate loading implantology. Ladies and gentlemen, most of you all would be knowing who Dr. Vivek Gaur is. I don't really need to give him an introduction because this person doesn't really need an introduction. But still, for the ones who don't know him, it's once again my honor to introduce our dear speaker for the second session, Dr. Vivek Gaur. Dr. Vivek Gaur is an oral and maxillofacial surgeon. He completed his BDS from Manipal. He went on to pursue his PG certificate in advanced implants from Manipal itself. Later on, he went on to complete a diploma in advanced implants from Holland in the year 2004. He is a certified master clinician in implants from UCLA, United States of America. He completed his master's in immediate loading implant from Immediate Loading Implant Foundation based in Munich, Germany. He is also recognized as a teacher of the International Implant Foundation, which is also based in Munich, Germany. He's been into private dental practice at Simpladent Clinic, Radisson Blu, Delhi, India. He's been a visiting consultant implantologist to various dental clinics across India and abroad for immediate functional loading implant dentistry. He's a mentor in courses in immediate functional loading implantology all across the globe. He's been a keynote speaker in various international and national conferences. He's got many publications under his belt. Ladies and gentlemen, over 17 years of experience as an implantologist, and he has placed more than 18,000 basal implants successfully to all patients all across the globe. Ladies and gentlemen, presenting to you Dr. Vivek Gaur live on the topic Simpladent, one-stop solution for immediate loading implantology. Over to you, Dr. Vivek.
Thank you, Mr. Vivek. Thanks a lot. I'm really thankful and privileged to have to sharing the screen and the conference, the first of the time, the virtual conference that is being organized by DentistChannel.Online. I'm really thankful for the innovative idea they have taken up, and we are blessed actually to give all the support and whatever the need is there to them. They are the youngsters. They are the brain of India and doing the innovative things and the conferences for hosting the conferences mm, and imparting the education to all the needful actually by the social media or by the webcasting. Thank you very much. So my topic is Simpladent one-stop solution for immediate loading. When we talk about the immediate loading, like I started the practice in 2003. Implants means I started the practice 2000 dental dentistry, and then for the implants I'm all into the implant from 2003 onwards, doing the conventional implantology. Conventional implantology means, in other words, how the Professor Scott Thickey says, it is alveolar implantology, because we are taking all the support from the alveolar bone. And then there was always a need was there. The patient was demanding, doc, how long I have to wait? And when we have done the grafting procedures, the sinus lift, the chin graft, whatever we have done it was taking too much time. And there was always the delay was there for the loading. And the patient, when the patient we were treating like a segmental cases, there was not a problem at all. But when we were talking about, when we were dealing with the resolved cases and we were dealing about the edentulous cases, in edentulous cases, the patient always want to have the teeth as quick as possible. And when the resolved cases were there, then there was a strict no. We used to find excuses, tell the patient, you know what is happening, you doesn't have a bone, and that's why there's a limitation is there of us, and we means we have to do the grafting. Grafting means you have to do the autogenous graft, like we have to take a fibula or we have to take a iliac crest. And you know, practically this sounds good in the institution, but when I'm operating or when we are operating in a clinic, in a private clinic, or we are operating as a consultant, no, I don't think so. Like hardly 0.1% of the patient, if they are lucky, are going to get ready for the grafting procedures that we have to do it actually in the general anesthesia. And then after doing the grafting, the autogenous grafting, I'm talking more about the autogenous grafting. I don't believe actually in the powder material, because for me in 2003, my first professor, Professor Ruth Hertel, always taught me that, you know, the gold standard is the autogenous graft. You know, otherwise you can just mix up all the allograft material is there to make a bulk, but the real thing is the gold standard is the autograft. I'm not going to into deep detail actually, because you all know. But for me, the Simpladent, it all started in 2010 when I got the answer of the immediate functional loading implantology by Professor Ede, and I saw the screw type implants and the disc implants, okay, the BO implant, basal also integrated implants. So there is actually the Simpladent. Simpladent is it's a sister company of Ede Dental. The pioneer is the Ede Dental. This is the office is there of the Simpladent in Gomeswald. It's in Switzerland. How it started, Ede Dental. Ede Dental, it was founded in 1954 in Berlin by the dental technician Mr. Klaus Ede. Mr. Klaus Ede is a father of our Professor Stephen Ede, the, the pioneer in corticobasal implantology. In the end of 1980s, Dr. Ede Dental GmbH, Germany, and Ede Dental AG, Switzerland got established. Simpladent GmbH and Biomed GmbH, the sister companies of Ede Dental, have footprints in more than 45 countries. But you know, this is all like any of the company can start talking. We have the offices in some 100 countries. We have office in the 50 countries. They can say like that. What is the unique concept of this case? The unique concept is they are focused on inputs from the users like us actually, what we are operators are, they are leading to new development innovations. I've seen like in a decade from 2010 when I started, how many of the designs we have improvised and we have changed it only because the Professor Ide and the team who are designing the implant, they are continuously asking us what need to be done more, so that we are going to have the more the predictable results and quicker the results and least traumatic for the patient. That is the USP. But really, I like the concept. And we emphasize more on spreading knowledge and specialized teachers program. You know, like there are the education universities are there, educational boards are there. They are teaching the implantology. But you know, when we talk about the immediate function loading implantology, in immediate function loading implantology, there were in 2010 like there were very few speakers who were talking about the immediate function loading implantology. I'm talking about a handful of speakers. For me, actually, the handful of speakers, the pioneers were Professor Linkov, you can say, and Karaknov. People don't talk about the Karaknov. Karaknov was the master in immediate function loading implantology. With the convention implants, with the rough surface implant, he has started the immediate function loading implantology. So here actually, the Simpladent or the Ede Dental, they are focused in teaching the doctors, and the doctors are encouraged to spread the knowledge worldwide if they choose to become the teachers, and if they choose to become the teachers, they just have to improvise the knowledge. As the Dr. Desa says, any book that is passed for more than 3 years, it's been expired. You know, like everything, the book also has expiry. You know, it has to be, the basics will remain the same, but the techniques has to be improvised. So what's our concept? The Simpladent concept is premium non-mercury or first to no harm. What does it mean? It means actually we are going to operate least traumatically to the patient. And the concept is treat the case as a whole. We do immediate function loading implantology. When we talk about the immediate function, of course, we are talking about the graftless protocols. You cannot do the sinus lift simultaneously and load the implants. As far as I know, actually, I have not seen it that you can do the immediate function loading or implantology by doing a sinus lift. Because the graft protocols is like that, they have to be stabilized with the less than 1 micron to 5 microns of the mobility. They cannot bear the mobility. If the mobility is there, there will be a scaffold formation will be there. Eventually, other than the autograft, all the alloclastic material you are using, they are now starting marketing as a delayed resorption or actually non-resorbing like that, because now everybody knows they doesn't get means it's just like a scaffold. You are not going to get the bone that is having a trajectory pattern. Do you understand what I mean to say? You are not going to get a histological trajectories are there. Trajectories are important for the functional loading. Your bone need to be function. It has to have trajectories. It is least expensive, most predictable. We are talking about the single piece implantology. We have the site specific designs are there. I'm going to talk about the number of implants, what the implant we are having. And of course, we always focus on simplified and practical. So, as you go with the classification, like the atrophic jaws, you all know the atrophic classification, the 1, 2, 3, 4, 5, and 6, the thing is there. Now, when we deal about the section 1 and 2, the subclassification, you all know actually you can place an implants conveniently because you have all the alveolar bone is available. But here we focus on the subclassifications like 4, 5, and 6, where the ultra resorbed cases are there, and here we are treating the cases. Okay. So there are the implants are there. These are, you can see one hexagon implant is there. I'm talking about the hexagon implant, but what the unique design of the hexagon implant is, you can see, I'm sorry, all the implants, whatever the implants I'm going to talk about, or the Simpladent dental, we all talk about the immediate function loading implantology. We all talk about immediate function. The immediate function means the implant has to be, the specific design has to be there so that the implant can function in immediate function loading protocol. So these are the implants that I will be talking later on. There are the drills are there. We doesn't have a fancy kit, having lots of stoppers are there and a different type of the torque control, different type of the instruments are there. We want to keep it as simple as possible. So you have a pathfinder drill, one 2-meter tooth drill, one zygomatic drill, 3 drills, widening drills are there like DOS drills. If you're operating like hexagon implants, or if you're operating the KOC compression screws, and we have the hand grip and the holder implant. We have actually for the torque control ratchet, and to torque it actually we have the different adapters are also present. So we talk about the HC2 implants. I'm thankful Dr. Jugal Patel who has given me the case for the HC2 implant, because like from last sinus lift and the augmentation, what I did it was in 2009, maybe November. So then I didn't do the conventional implants. I'm all in the immediate function loading implantology. But yes, Dr. Jugal, he's doing a 2-piece implant. And the other is, other than the HC2 implant, what I'm showing, all the implants are single piece implants. We are emphasizing on single piece implant. This is only the implant that is a 2-piece implant is there, and definitely 2-piece implant also have the advantages there. The advantages of the 2-piece implant is you can choose your abutment, you can choose the gingival margin, you can choose the bone level, and then you can create an aesthetics. And you can create an aesthetic with the single piece implants also. There's a learning curve is there. The best part of this implant is we have a polished cortical threads up here. So it just engages the cortical. Okay. It compresses the cortical and have a higher insertion torque will be there. So these are the type of the hexagon implants are there. And you can see there's an internal, the reverse bevel is there so that you are not going to have any the stresses, undesired stresses on the first cortical level, means at the crystal level. Sorry. Different type of the hexagon implants are there. These are the drilling protocols are there. Just as you know, actually all the companies are, all the instrument, all the these implant systems have the drilling protocol. You have the pathfinder, then you have the 2-meter tooth drill, and then you have placed a particular implant. With for wider diameter implant, you have to widen the osteotomy with the draw drills, and you have a C drill also there, that is a cortical drill, so that the first cortical should get relief, and all the stability we are going to get from the second cortical. What is the second cortical means? I'm talking about a nasal cortical, I'm talking about the sinus floor, I'm talking about the pterygoids also. Okay, I'm talking about the lingual cortical. These are the second corticals are there. Pterygoids and zygomates are in fact the third corticals. So we'll talk later on, like my next lecture will be there, we'll talk about more. So these are the hexagon implants. You can place it, and that's how the Jugal has done the nice presentation actually. And now this is how we carry the implant and you can place the implant. The best part of these, see, all the implant system having a different type of abutments are there. We also have the multi implants are there, angulated abutments are there. What I talk about here, we are talking about this TCA abutment. The TCA abutment is like it's a screwable abutment is there, like it's a single piece abutment is there. So you don't have an extra screw is not there. The abutment itself is have a screw, and when you are going to torque it, it just becomes like a single piece. Implants have a good predictable results are there. So as you see, the infected socket was there, done by Dr. Jugal Patel from Hubli. He did the care task, placed the implants, and this is what the situation was that. And later on, there's a nice healed socket was there with the predictable crown. The result. This is also a case is there. After extraction, you see the cortical, the nasal cortical has been engaged by the implant. You know, it's like the sinus fluid was engaged by the implant, by the cortical threads, and how it has been completed. This is the beauty of the Hexagon implant. You don't have to do the sinus lift. You just have to perforate the cortical, the nasal cortical sinus fluid, and you have enhanced the insertion torque or the stability you are going to get it. So this is some of the case of the HC2 implant is there. Now I start with the advantage of single piece. Simpladent is being Simpladent dental. They focus on the single piece implantology. Why? Gingival level prosthetic margin. Please understand, when we talk about the gingival level prosthetic margin, it is just like a natural teeth. How the natural teeth are there, when we are doing a crown cutting of a natural teeth, we are not cutting to the bone level, you know, we are just cutting at the margin, the gingival margin. We are keeping for the posteriors, we always tend to keep, as been taught in our dental school, for the posteriors, we always advise to keep the supragingival margin, and for the anteriors, you can keep a subgingival margin. This is the basics are there. So what we achieve, when they see, when we are going to have a micro motion will be there. If the abutment margin is coming at the bone level, you are going to have a bone level micro motion will be there, and that's create a complication. So if you're having a micro motion at the gingival level, gingiva really adapt with the titanium very well. And we have a no correction means no complications. Extra gingival biotype, you're going to get it. Negligible crystal bone loss will be there if your margins are at the gingival level. Simplified prosthetic steps are there. It is least traumatic because we always do flapless whenever possible. And when you talk about the evidences, you know, they all talk about, you know, we don't have any evidences of the single piece implantology because we were not looking properly, we were not searching properly, we were just relying on the spoon feeding what the other mentors we were giving to you. We have the sufficient evidence support is there for the single piece implantology. In fact, the maximum support, the evidence of the long term you're going to get is only for the single piece implantology. The implantology started with the single piece. Sorry. So these are all the plenty of articles are available. You can log in with the www.simpladent.in. There is the section is there that is called the article section, publication section. You can just download free of cost all the articles. Now we talk about the single piece implantology and we talk about the compression screws. Now so many of designs are no good amount of implants are good. Different companies are coming, they are getting up with the similar designs are there. And this design hold back long time from the Tremonti days. And here this implant you are having a compression, the screw is there, but the most important part is the pitch. Pitch means the distance between the two threads. If you have the threads are there and that is too close together, then they are not going to condense the bone properly. They are going to separate the bone. So the pitch is very important. So whenever you are choosing the system, just understand what is the pitch is there. The distance between the two threads are there. Okay, and at the crystal part, we have some polished surfaces also there, so that when you're doing a flapless operations are there. So maybe apart means the crystal level, it's never a flat plane is there. It is always maybe more in the mandible or in the maxilla. It's always palatally it is of greater height than of the buccal the aspect. So that's why if you're having a crystal or polished surface sets are there at the crystal level, so you are not inviting the when the crystal bone resorption occur, you start a cascade of peri-implantitis because of secondary vagination of bacteria will take place on the rough surface. Here the probability is negligible. We have a cost plus implant is there. That is my favorite. Cost plus implant means we have a polished cortical threads are there. So I will just show you actually the polished thread means we are condensing the alveolar bone also and we are condensing the cortical bone. The cortical bone gives the maximum insertion torque. So here there's a case long done by me. Maybe I had done this case in 2012. Sorry. So immediately extraction I did it, did the curettage, sink the implant, place the abutment margin at the bone level, restored the implant, and the follow-up is like that. You can now see the patient was a smoker, and the single piece implantology when you doesn't have any micro motion or any new or not repeated impressions are not there actually at the gingival level. The gingival really cover ups very well. So should have the knowledge of the bone, and aesthetic is not a problem. Now the BCS X implant is there. What is the X implant is there? Is through and through polished is there. The uniqueness of this thing you can place in an infected socket, but where I prefer this implant when you are going to respect the jumping distance, mean when you are doing the extractions. After extraction, like this, some particular this case is there. If you are extracting and if you are placing a narrow body implant, obviously if you are not doing a grafting protocol, you have, even you do a grafting protocol also, there always a collapse of the buccal cortical will be there. But in this case, if you use a wide diameter implant, like the BCSX implant, you are going to get the support. So this is a pre-op was there, the post-op immediate post-op is there, and you can see this immediate follow-up was there, immediate the picture is there, and I will show you this case is like done more than 2 years or 3 years around, but I will show you a 1 year follow-up, and I'm going to show the clear picture without polishing it. This patient was a smoker. It was done in Calcutta. This patient is a heavy smoker. Smoking means soft tissue recession will be there, but I'm going to show you the result. See, this patient was a heavy smoker was there, and you can see the adaptability of the soft tissue with the single piece implantology. Now, the other cases, whenever, like nowadays, usually in the like the conferences started, the virtual conference, many people and lots of speakers will be talking about the pterygoid implant, they will be talking about the zygomatic implant. Please, I am telling you that whenever you have a design of the implant where the taper design is there, taper design means at the crystal level you have a wide body is there and it's getting tapered, you are not doing a pterygoid implant. It is a false, it's a misnomer. You are doing tuberopterygoid implant. Means whenever you have a tuberosity is there, then you can condense the tuberosity and you can engage the pterygoid. But if the tuberosity is not there, when we talk of routinely the atrophic cases, and only the pterygoid is available, then these implants, the rough surface implants or the implant like the BCSX implant, what I'm showing you, having a white crystal, the crystal part is there, the white crystal part is there, it's not possible to engage this implant because you know the only the pterygoid is available, the tuberosity is not available. So whenever you have a speakers, good number of speakers are there, they're going to talk about the pterygoid implant. Please tell them, change the topic, just say tuberopterygoid, don't talk about the pterygoid implant. Now we have the hexagon implant is also there. This is really good implant is there. What is the specialty? It is a single piece implant is there. Okay, it's a single piece implant is there, but you have a retrievability option is there because the screw is up there. So this is a case is there, operated, how we do it, we have an insertion tool is there, and then this is how we do our tuberopterygoid implant with the hexagon because the tuberosity was available. In the anterior, we engages the cortical, the nasal cortical, and that's how we engages. Okay. Of course, why the flap has been refracted because it has been flattened out. Now this is the case is there. You can see the lingual cortical. The lingual cortical we have engaged, and that's the post-op was there. And this is the T bases are there. T base connect as a gingival former. Then we have two options are there. Either we do a open tray technique with the direct sprinting with a pattern resin, or you can do actually we have the scan bodies are available. You can do the intraoral scanning, and that's how the prosthesis is being fabricated. Okay. Now we talk about the BCS implant. I have to go a bit quick actually. You know why? Because the time is short. BCS implant, that is my favorite. You know, that is not my favorite. When you're dealing with the atrophic cases, and atrophic cases, when you talk about atrophic cases, what does it mean? There is nothing like a crystal bone available, the crystal bone available. We are talking only the cortical bones available, the nasal cortical, floor of the nasal cortical or exudative floor of maxillary sinus, or the pterygoid of the zygoma, the lingual cortical base of mandible. What the beauty of this implant is the bendability. And now I see the lots of companies are coming. Means I feel so happy in 2010 when I was placing this implant, the people were making maybe a joke or laughing at the back, saying, what this screw type of implant you're placing, this not an implant is there. It is just like a screw is there. But the fact is implants, they are fixtures and they are just like screws. This implant is based on the leg screws. Okay, it's Tolong leg screws this implant is based on. And now the company, I can see, they are started replicating this implant, duplicating the implant, and they are making either they are making the pitch very short, means lots of threads are condensed together, so you are not actually condensing the bone, you are separating the bone, or threads are too much of threads are there. The concept for those dentists is when too much threads are there, you can place anywhere, somewhere it is going to engage. Please, implantology is not like that. Somewhere it has to engage. You have to be target specific, site specific, and you should have knowledge where to engage it. So when you have too much of threads are there, it loses the isoelastic design. You cannot bend this implant, okay? Because single piece implantology, the most important drawback is the bending the implant, making the prosthetic, the abutment to a desired prosthetic location, and that can be achieved only by bending of the implant. So these are the different type of the implants. So I can just show you actually a uniqueness of our single piece implant. Case was done in 2012. You can see in 2012, like the ideal, till now, the ideal protocol is if you having a destructive periodontitis is there, you just have to take out the teeth. After taking out the teeth, you have to wait for 6 weeks, then you are placing an implant. Even you are placing an implant, the prognosis with the rough surface implant done in a patient having history of periodontitis is questionable. Okay, this implants I done it, and you can see at the 4847 region the bone level, and now I am going to show you the follow-ups. The bone level is started actually. Okay, the bone has started coming up. Why? Because all the force dissipation is taking place at the lingual cortical. There's nothing like force dissipation or the force distribution at the first cortical level. So the bone always want to grow, want to retain the original position. Earlier we having a metal to acrylic prosthesis, we have given it, and later we change it to the ceramic restoration. Now you can see how much the bone level has done, and this is the latest X-ray we did it on March 7th March 2020 before the lockdown, and you can see the bone level. So this is the beauty. This is the best part of the single piece implantology, where you have a polished surface that is there, no force dissipation at the first cortical level. So now as we talk about bone, the atrophy is just not like there's the crystal bone is not available and only the corticals available. This atrophy is there. There is a prescribed classification is there, like in the mandible. You feel good amount of mandible bone is there, and inside what is there? Inside the only fatty marrow tissues are there. This is like a classical when you have osteopenia is there or the osteoporosis is there. These are the patients are there. You have to operate, and you doesn't have any alveolar bone available where you can place a conventional fixture or the conventional implant, and you can see and you can hear it. Like I was placing an implant, and suddenly the implant slipped inside in the bone, in the mandible, and that is like a big problem is there. People share joke also, but please understand, when you placing an implant just slip inside, it means you are dealing with the subclassification 5 or 6 or 4 of paraschemic classification. For this implant, you have only one option, that is the thesis implant. This is a case long time when done it, like in 2014 I did this case. It was very challenging, and for me because we are doing rightfully the single piece implant, the immediate function loading implantology, so there is a very strict no for the cantilevers. We don't believe in cantilevers. Like for the last, you can say everywhere there was a thing was there that they all talking about the all-on-4, but now I see the same mentors who are talking about the speakers and mentors talking about the all-on-4. Rightfully, at least for the maxilla, they started placing the 6 implants or 8 implants, because the biomechanism of jaw is different in maxilla. So you have to place an implant, you have to put more number of implant, and you have to minimize the cantilever. Cantilever situations are always you have to avoid. So this is the situation. You place an implant. After placing the implant, you have to bypass the. This is how we, when the atrophic cases are there, the canal is at a crystal level. So you just bypass the canal. Okay, so I'm going to show you. The routine, the maxilla, we did it with the pterygoid, engages the nasal cortical. I go a bit fast because my next topic tomorrow, the topic is I can tell you in detail how we are doing the immediate function routing implantology. That topic is tip and tricks for to doing immediate function routing implantology. So I will be more specific, but this is like the pterygoids were there. Nasal cortical engagement is there, and in the mandible you can see it's a clear-cut bypass is there. When I did in 2014 the bypass, I was so excited, to see I did the nerve bypass, but I did it with the flap. But now we are routinely doing flapless nerve bypass. This is like how the learning experience is there and how we are getting mature in the implantology. So you can see this nerve bypass is there, metatarsic framework has been done, pre-op was there, post-op is there, and that's the follow-up is there. Another case, now this is the case actually we did with the flapless. You can see the atrophic cases. It was done recently, like 2 years back. So this is how the double pterygoids we do it. We do the palatal way. Through the palate actually we engage the nasal cortical. The buccal bypass we have done it, as you can see. It's all flapless. That's the metal to plastic process is there, and that's how we do it. Now, we are going to talk to you one thing different. The beauty of the single piece implant. You have never seen a case like that. Which is the case I will show you. This is a case of a non-healing fracture was there. There's a non-healing fracture was there. What I did, I placed the implants because I know when you're going to fix the prosthesis with a metal framework, actually you are enhancing the stability of the fracture jaw. And that is, you can see this implant post-op, immediate post-op is there, and that is the result is there after 2 years. This you are not able to see anywhere with any conventional implantology. This is only and only possible with a wonderful tuning leg screw based BCS implant. Now we talk about the aesthetic. We all been criticized. We people are not good. Okay, we people are doing good in the atrophic jaws, but we are not able to produce the aesthetic results. I emphasize by understanding biomechanics of bone, aesthetic is never an issue. You will see actually what I mean to say. Check out the case. You have an implant is there, and how the case started. The case started. It was a fractured tooth was there. The trauma was there, and that is the result is there. How we achieved it, I will tell you. This was a fractured tooth was there. We did the orthodontic extrusion. After doing orthodontic extrusion, we did the socket shield. Please understand, we have done orthodontic extrusion. The bone is in a state of remodeling. The fracture segment, the shelf, actually the root membrane is not so stable. So it was a tricky thing was there, and it was a risky thing was there. But I did the socket shield, placed the implant, immediate restoration of the crown. No, like it's a permanent crown is there. It's nothing like a temporary crown for me. That's how we did it. With the follow-up, and that is the result, as you can see. So if you know the biomechanics, if you know the technique, aesthetic is never an issue. Now we have like I was talking about the single piece implant. We have the multi implants also there, as I've already explained in the Hexagon MU plus implants. We have BCS MU implants also there for the atrophic cases. Again, the insertion tool is there, and this is the extra instrument you have to buy. It is like just the insertion tool and the hexagon, nothing else. Okay, all the routine instrumentation will be there. What is specific? What is the best part of this? I am talking about if there is connection is there is going to be a problem will be there. Here we are having a margin at the gingival level. Mean there's a single piece implant is there. Being a single piece implant, the abutment come. The TVS come, the abutment and the implant is a single piece, and there's a margin of the abutment is there that is going to keep at the gingival level. and the T-base will be there. Over the T-base, the castable is there, so the process going to come over the T-base. So it is a screw-retained cementable processes will be there. So the trauma to the or the forces toward the screw will be negligible. So you are not going to have a loosening of the screw will be there. Otherwise, always and always you're going to have a loosening of the screw will be there if you are having all the forces transmitting through the screws. Whatever the design of the implant is there, whatever the other than the more stripper or other than the single piece implant, if there is a connection is there, there's always a chance of the screw loosening or screw fracture will definitely be there. Another unique case is there, did the reduction, simultaneous all the 6 anterior teeth I did the socket sheet, place the amio implants, retrieval prosthesis, and that's how we have completed the case. Immediate post-op follow-ups. That's a follow-up is there. Immediate pre-op, post-op, and that's a follow-up is there. Okay, so aesthetic is never an issue if you really know the techniques and know how the bone is going to react, because hard tissue, soft tissue follows the hard tissue, so just concentrate on the hard tissue. Now I had actually this wonderful implant. One more implant is there, that is a zygomatic implant is there. It's a single piece implant, the zygomatic implant. What does it mean, a single piece zygomatic implant? You can see it's a through and through, it's all polished surfaces there. And at the crest level, you have a cutting threads are there. When I started started learning of the zygomatic implant, there was the pioneers are, of course, actually our Professor Brandbach sir is there, the pioneer for the zygomatic implant. Then it matured. Then it matured with other speakers have also come, like Stella and Warner technique was also there. But what I am talking about, earlier the implant design was all rough surface design was there. And they were promoting the rough surface design. They were promoting the rough surface design like that if the rough surface is getting exposed to the soft tissue, there will be peri-implantitis will be there. So you have to follow a strict protocol will be there. Strict surgical protocol is there. The rough surface should not get exposed to the soft tissue. The bone has to be there around. But suddenly you have started placing the rough surface implant on the side, on the zygoma, and the rough surface was getting exposed to the soft tissue, and you say, no, there's not going to be any problem will be there. So why you are playing like the two type? There was definitely problems were there. Then you have started improvising the design, and the latest zygomatic implant that's available are of course, the two-piece implants are there. They have the separate abutment is there. They have the multi-abutments there. But another factor is that these implants are at the rough surface, at all over the means rough surface is there at where you have to engage the implant apically, and rest of the surface they have made a polished surface. So actually when the rough surface is going to get interact with the sinus lining or actually the mucosa, or you're going to get it with the buccal flap, you are or definitely going to have a problem. Another aspect is when you do the zygomatic implant, because I have done plenty of zygomatic implants. I started doing this zygomatic implant in 2014, and I have matured enough that I do only for the last 2 or 3 years. I'm doing only flapped zygomatic implants. I don't reflect a flap when I'm doing a zygomatic implants. I'm not talking about the zygomatic implants. I'm talking the engagement of zygomatic implant in the zygomatic arch also. I'm talking, okay, this all the means we can show you, I can show you the results tomorrow when my other lecture will be there, what are the techniques are there for the two places zygomatic implant. And these implants has a specific, they have the bendability is there. So when you, after placing an implant, they have a bendable zone is there, you bend the implant, and when you are going to bend the implant, the abutment will come down to the desired prosthetic position. What I was mentioning, that this implants all in all smooth surface implant is there. When you do a zygomatic implant, you have to externalize the zygomatic bone, means you have to perforate the zygomatic bone. And if the perforation is there and you are using a rough surface implant, it get exposed and get in contact with the with the skin, then you are going to have a problem. Skin, what I'm talking about the skin, because the zygomatic implant, buccally or vestibularly, you are going to have a skin is there. So you are going to have a problem will be there. like retrograde infection can be there, retrograde periimplantitis will be there. But in this cases, when you talk about the smooth surface implantology, we don't talk about the periimplantitis at all. You can see that there are the different techniques are there. When you are taking out a slipped implant in the sinus, the conventional implant, you have to make a hole. You have to make an opening, take out all the lining. You have to take out the mucosal and displace the implant. This another technique is there. Another technique is there when you do a flapless implant. You can see how the flapless implant is being done. Means patient you take, like earlier it used to take, it's a learning curve is there. It used to take around half an hour to 1 hour to place a zygomatic implant. But now as the more and more cases we operate, the more experiences we gain, and we improvise ourselves, and we are taking a minimum time to place a zygomatic implant, like hardly 5 to 10 minutes. It's maximum to take a zygomatic implant flapless, and we are doing all in the local infiltration. We don't talk about the general anesthesia. Okay. Now I just show you the case. What is possible with the smooth surface implantology? See, like this implant is actually called like a oncology tool. It's an oncology implant is there. We have written lots of articles is there. Started getting published. The recent publishing, I got my article published in International Journal of Case Reports, and there I mentioned, and we have that this implant, the smooth surface pterygoid zygote implant, should be better called as an oncology tool or oncology implant. What I mean to say, that when you have no alveolar bone is available, only the corticals are available. So how you can place an implant that's where wide body is there at the crustal level and the taper is there? No, you just need an implant, just like a screw, like the leg screw. You need it, so you have to fix it with the cortical. So this is the bone is there, in the case with the post mucormycosis resection cases there. And what you does actually, you have all the corticals available. You do the double pterygoid zygomatic implant as a nasomaxillary buttress. You just engage it. So there is no wide body is there. There's no force dissipation is there at the crustal cortical, because there is no crustal cortical is there at all. So you just place the implants. These implants, the zygomatic or the BCS implants, BCS implants in the cortical, smooth surface cortical apical threads are there. They just engage the implant, they engage the bone, and that's how the success stories start. Okay, we are just showing you the follow-ups. Now, I just show you one case. I'm not going to show this case in detail because already all the cases are in publication. But how we have changed the scenario, like when you talk about the atrophic cases, and I see the presentation of the atrophic cases, there are the good experienced surgeons are there. They are doing a wonderful job with the implants. They have a highly skillful surgeons are there. I have real high regard for Dr. Sankalp Mittal, my very good friend. He is really a good surgeon. But the thing is, if you are a good surgeon, you need a right equipment also is there. Okay, for the right equipment, you need this BCS implant, the smooth surface implant. These are unique cases there, where for the first time you can see that's atrophy is there. This is the atrophy is there, post-section of squamous cell carcinoma of the anterior of the maxilla. And what we achieved, I did the flapless zygomatic implant placement in the glabella. So you can see zygomatic implant, pterygoid implant, and the one implant actually at a glabella. Okay, so this is what we want to achieve. Okay, you see how simplified the design is there. So when you have a simplified tool is there, you can achieve the results, and you can end up giving the patients a product or the final thing that the patient has come for, without having much going in the grafting procedures or the expensive grafting procedures or not so reliable grafting procedures for such cases. You can see how we have achieved it. I am not showing you clinical picture because already the case is there in the in the publication. But this is, we have achieved a next level in implantology. This case was done a year back by me, and this is what I call the next level implantology. Okay, the real. So I am really because now we have given the time for 45 minutes. Already the 45 minutes is going to get over. I acknowledge Dr. Jugal Patel and Dr. Anita Gala Doshi for Dr. Jugal Patel actually for the Hexagon implants, and Dr. Anita Gala Doshi because whenever I operate the MU implants, she is my prosthodontist and she take pictures and she complete the prosthetics. Now, if you are really interested to treat atrophic cases, I mean, I'm just going to tell you a story. The story is, let's say an orthopedic surgeon is sitting there, and an orthopedic surgeon, he just has an engagement in the evening. In the evening, the orthopedic surgeons want to go to have a like he's have a some time he has given for his family, and they want to go out actually for the dinner, for movie, whatever. And a trauma case comes, and it is just like a simple fracture is there, or your hairline fracture is there. So the orthopedician is going to tell, okay, you that he's going to instruct the nurse. The nurse, please, you just make the patient comfortable, and you have to admit the patient because tomorrow we can operate, no problem. But when you are going to have multiple fractures there, complex multiple fractures there, computer fractures are there, that surgeon, the orthopedic surgeon, is definitely going to cancel his evening appointment. He is going to stop. He is going to operate at right that moment. What is happening in implantology, in our implantology, when we have a cases there with good amount of alveolar bone is present, we are, and the patient can survive with the denture also comfortably. We always want to educate our patient to make it, to give it, actually, to make it to turn that patient to the implant restoration. And when we have a real atrophic cases are there, we start finding the excuses. For me, whenever I have a real atrophic cases there, like the post-resection cases are there, or you have the pencil mandible is there, highly atrophic maxilla is there, and because I know I have a VCS implant, the zygomatic implant is there from the Simpladent, from the dental, so I can just complete the case. So you all, if you want to mature yourself to do immediate loading, we are proud to announce for the first time in India, it's a diploma in immediate loading, and it is from Maharaj Vinayak Global University, Jaipur, India, in association with International Implant Foundation. There's a diploma program in immediate loading implantology in Jaipur Dental College. Okay, so these are all the speakers are there. So again, I end up with the logo that we compete when others have given. Thanks a lot, because I have told the 45 minutes will be there for the lecture and 15 minutes will be there for the questions. So I thank you very much. So you are there as an audience, and I shared my lecture, and tomorrow I will be talking about the tip and tricks of immediate loading. Okay, I will give my experience of the immediate loading for more than a decade.
Thank you, Dr. Vivek.
Thank you very much.
Once again, on behalf of Team DentistChannel.Online, would like to thank you for covering the complete lineup of products at Simpladent. I think, ladies and gentlemen, it is not that easy to understand the complete lineup. Unanimous, wonderful lineup of one-piece implants, and I'm sure you would want to know more about the implant system. Well, before that, ladies and gentlemen, if you liked the presentation, I want you to put in your comments and tell us how well you liked it. If you found it beautiful, if you found it wonderful, if you found it was an exciting lecture, or whether you are interested to know more about immediate functional loading implants, or whether if you would want to be a part of numerous and his team keeps conducting all throughout the year, please post it in the chat box. We would love to hear out and read all your appreciations. Thank you so much. Ladies and gentlemen, at the same time, I would like to tell you to please feel free to post all your questions in the Q&A box. We are running short of time, but I would request Dr. Vivek to cover all the questions in a short answer. Before that, I am running a poll now, and I would request all our participants to kindly answer to the poll. Thank you.
So that's the first question is there. We will get certificate this or not, I don't know. What does it mean? Now, Dr. Manoj Kumar says, is there any effect on scaling of the implanted teeth if there is a plaque around it? Of course, I would like to know more about the special discount offered by the Simpladent. Okay, there's a poll is there, it's not for me. So is there any effect of scaling on the implanted teeth if there's a plaque around it? Yes, of course, actually, if you are going to use any of the material, any of the metal, any of the thing against the implant, you're going to create a micro scratches are there. So micro scratches, if you have a rough surface implant is there, obviously you cannot do any scaling, but on the abutment, if you are doing any instrument, if you are going to move around the abutments, you are going to create a micro scratches. Please understand the word is biofilm. Even I am having a polished surface implant, I am definitely going to have a biofilm, because before the biofilm, there is a conditioning film will be there. There's a conditioning layer is there, over and the biofilm is there. And the biofilm is attract the proteins, and later on the pathogens are going to get attracted. But when you have a decimetric, when you have the threads are there at the other level, like far away from the crystal particle, this the pathogens or this the infection or this the bacteria are not going to get transmitted to the load sharing areas where the implants have been engaged. So here actually you are getting devoid of the peri-implantitis. But if you have the rough surfaces there, then definitely is going to catch up, and then the disease will start. Can we search for implanted pain suffering osteoporosis? Yes, we definitely, we daily do with the osteoporosis, with the rheumatoid arthritis, with the osteopenia patient. You know, the idea is to use a polished surface implant and do the maximum number of implants in a job. Name of medicine which enhances osteointegration. For me, the name of medicine is the Implanted Simpladent implant, the smooth surface implantology. Basal, basal implant and indication. When others have given up, you complete the case. It means when your rough surface doesn't work, the basal always work. And it also means when the rough surface is working, that of course the basal implant is always also going to be working. Okay, so every case has its indication. Every case is indicated for basal implantology. So what is immediate dental protocol? Tomorrow we are going to discuss. So may I know the extra osteointegration success, especially with Simpladent. Do you know when the word is there, osseointegration is the biological answer of ossifixation. So whenever you are doing implants in a highly mineralized bone, it is getting ossifixated. And any system that is stable for more than 2 years, it is stable for lifelong. Please understand the meaning. So it is like that. Any system that works actually for more than 1 to 2 years is for lifelong. Please explain immediate splinting. Immediate splinting means when we are completing the splinting means we are splinting all the implant with the metal framework for the processes, and that's how we have to do within 72 hours. Why within 72 hours? Before the bone remodeling starts. Okay, you can discuss tomorrow also. Reliable method of assessing osteointegration of dental implants. The most reliable method is there is no mobility is there. You have high insertion torque is there, and the patient is smiling, and you are also smiling. Is glabellar implant interfere? No, it doesn't interfere respiration. You know why? Because the case was having the we have given the nasal episthesis also, because there was no nose was there. So we have done it. This is a unique cases was that for the first time it is done, and like we did a trapodization of the maxilla with a zygomatic implant, pterygoid implant, when implanted the glabella, and it's a one framework design was there, and with the one framework, the intro only we are giving the fixed processes, and with the body of the implant, zygomatic implant, we are given the nasal episthesis. So it is good. Sir, can you use a geriatric patient? Sir, I am operating only the patient like this coming, like most of the 90% of the patients are of the age between, you can say, 70 to 90 years, and like 2 years back I operated a patient. She is 96 years, so now she will be 98 years old. Is the condition filming biocompatible? Is the condition filming biocompatible? Condition filming, condition, you're talking about a condition of the implant. See, the condition of the implant, you are talking about conditioning the implant, make it more hydrophobic or hydrophilic. Hydrophilic will definitely attract the biofilm, this thing, the biofilm, and if the hydrophobic is there, it's not going to enhance your osseointegration, but it definitely, if you are placing the hydrophobic implant as a mineralized bone, so you are not going to have any chance of peri-implantitis. Okay, this is the thing is there. And we do, and other aspect is we always want to decrease, we want to make the surface roughness less than 2 microns for the perfect, then there will be no biofilm accumulation will be there, and we want to decrease the surface energy of the implant. Can we flex these? No, we cannot flex this basal implant, we can bend basal implant only once. Okay. How how are these implants where there is no need of drilling like how are those implants where there is no need of come on, we are doing osteotomy. There's nothing like a magic is there. There's all tactile sensations there. Is hydrocephalus bed system, HF system better? Are there any better options? Of course, we have a full product details of the implant and depends upon when you're having a rough surface, when you have the annual bone is there, you can use you can use a hexagon implant, you can use a cos implant, anything implant you can use it. Okay, when you do it and when there is no cancellous bones available, elbow bone is available, then the only option left is for you is if you are doing interested in graft test protocols, highly predictable graft test protocols, then the answer will be the BCS implant. Can we use single piece implant in case of multiple fractures? Mm, See, you cannot explain the fractures, but you if you have the fracture is there and the splinting is needed, you are splinting with a metal framework. We are not splinting the fracture segment with the implant. Please understand what I want to tell you. Do we encounter fracture of the definitely we encounter fracture of the implant when you're torquing it more than 110 Newton. But while functioning, this implant is not getting fracture. This implant will definitely get fracture when you have the decementations taking place all over the implant. Only one implant or two implants holding all the prosthesis. So definitely it's all osseointegrated, also fixated. So the implant body can fracture. What instructions should be given to the patient? Live happily, enjoy your life. Is it appropriate to do immediate implanting pedo patients, sir? Please, I don't know. I am not going to operate any patient that is less than 16 years of age, a female, and 17 years of in male, because the implant will be also integrated, but there will be a different gingival or the biotype, or actually the bone level will be different because the growth is taking place. So I have not done it. How we bend this implant? Horizontal forces deteriorate long-term process. There's nothing is like that. Okay, tomorrow we can also talk. We can bend the implant by the ratchet or by the hand grip, and then we are splinting the implants. Okay. So there is the load sharing is taking place on all the 10 of the implant you have done it, or the 2 or 3 implant. How to convince a patient to go for implant? Yes, this I have to learn today also, because after the COVID times, I also have to convince a patient to go for implant. We both like the financial stress has gone all low at the level. So we both will try to learn how to convince a patient to go for implant. Luckily for me, the patients are coming for me when they doesn't have any options there. So I'm thankful to God.